This is Selma Schimmel in Milan, Italy, where we are at the ESMO Congress. That is the European Society for Medical Oncology. It's the 35th Congress, and we're taking time to sit with physicians and researchers, clinicians from all over the world, the U.S. included. And I am now joined by Professor Dorothy Keefe. And Professor Keefe, I love what you do. Not only are you a medical oncologist, but you are the president of an area of supportive care, probably the leading and only organization of its kind, the Multinational Association of Supportive Care in Cancer. It is the only one, is it not?
It is the only international one. We do now have some national affiliate organizations that we're trying to grow around the world, but we're the only international one.
Yeah, and the multinational component is very significant. And to me, as a cancer survivor, the idea that a medical oncologist has carved out a niche in supportive care is so significant, because my sense is supportive care kind of gets pushed into this area of, well, you know, it's important, but it's really not that important. And for the patient, there's nothing more important than supportive care, because without it, you have no quality of life.
I would agree with you, absolutely, and I think our membership would too. We have members from more than 60 countries around the world, and they span first, second and third world. And so we have the first world countries where the care and the supportive care is better than in the others. I wouldn't say it's excellent anywhere. And then we're reaching out to the other nations in the world to try and bring up the supportive care levels there too. It's interesting you say about being a medical oncologist, because we're also a multidisciplinary organisation. About 50% of the membership of MASCC is medical, and the rest is made up of nurses and social workers and pharmacists and researchers and anyone who has an interest in supportive care.
Would you take a moment and define supportive care?
Certainly, that would be a real pleasure. I think supportive care has been defined in many ways by different people, but MASCC takes a very broad view of the definition. For us, and I think probably for patients, supportive care is the management of the toxicities of cancer and its treatment right the way along the cancer journey. So we're talking about prevention, we're talking about management of toxicities of treatment of cancer, we're talking about pain management, psychosocial, rehabilitation and survivorship.
As a survivor, I feel that the area of supportive care needs to be included from the very first consult. The very first time you're going in, you're talking to your doctor about what your treatment options are, that the supportive care discussion should be integrated right into your clinical discussion, and it doesn't always feel like it is.
Again, you're absolutely right. There is a need for supportive care to be integrated at every single step of the patient journey, and it's different at different points along the journey. The needs of the patient change, so we need to have at diagnosis one set of supportive care priorities, which are really very much around psychosocial and making sure that the patient has the supports they need to deal with the diagnosis and the early treatment. During treatment phases, the supportive care is often about toxicity management, chemo brain, nausea and vomiting, mucositis, all the horrible things that happen to people. And then at the next stages after treatment, it becomes about recovery and rehabilitation. And this is something that we do need to build into the cancer journey right the way.
And also where physicians encourage patients to share and document what their side effects are, not only with the physician but the oncology nurse.
Again, this is one of those areas where I think traditionally there's been a tendency to not ask the patient about the toxicities, because it's quite depressing to hear how bad the treatment is, especially if you can't do anything about it. So one of MASCC's missions is to research the toxicities and educate people about how to treat them, so that we can empower everyone who's involved, the nurses, the doctors and the patients themselves, to actually document those toxicities and deal with them. We know mucositis, in particular mouth ulcers and diarrhea,
right.
If you give patients control over their own treatment for it, it's less bad. So
it's interesting that you say that, because I always tell patients when they start treatment, get a small spiral, small enough that if you're a woman you can throw it in your handbag, and that you write down every day whatever side effect you're experiencing. When you go into your medical oncologist, that you have that as a tangible document that you can look at your doctor and look at every single side effect that you may be experiencing to help your doctor figure out whether you need a dosage reduction or whatever drugs you may need to get you through whatever situation that you're facing.
exactly. And also in this modern era, shouldn't we also be giving people electronic data capture opportunities? What I mean by that is a tablet computer that lists all the toxicities,
Yes.
and you just press the screen where, an iPad or whatever, press the screen to document that toxicity and discuss how bad it was, and then that can be downloaded into the doctor's computer, and when they see you, they have all of this information. Now, there are studies going on in the US of this very technology, which is a fantastic step forward. And of course, with the development of every new drug, with the new toxicities that come along, that would give us a much faster real-time access to the patterns of problems that people are having.